are at the junction of the supraglottis and the hypopharynx. The etiopathogenesis is again tobacco and alcohol, the nemesis of a head and neck cancer surgeon. Both in a smoked and smokeless form, the laryngeal cancers are responsible. So when a patient tells you that he is a smoker, he is more likely to get a laryngeal or a lung cancer, if it is a chewer and a drinker, he is more likely to get supraglottic or hypopharyngeal cancers. Both these, tobacco and alcohol, they will have a linear relationship with the addiction. But then when you combine them together, alcohol, tobacco, they will have a multiplicative effect, and both of them together will increase the relative risks to about 40, while individually is somewhere between 5 to 34 depending on your amount of consumption. So there is a direct dose response relationship here. There are multiple other occupational factors that have been put into etiopathogenesis, which are like industrial, metal processing, sulfuric acid, toxins. Also, newer theories of dietary factors have been coming in, such as a diet which is high in diet inflammatory index. So what do we mean by that? That diet who is high in carbohydrates and saturated fatty acids, that is pork, sugar, cheese, meat. More importantly, for us to know, anemia is the most important cause called by Plummer-Vinson syndrome, responsible for post-cricoid cancers, especially in women. And very rarely you would have genetic diseases. Human papilloma virus, although related, it's not a major early proven cause for laryngopharyngeal cancers. So first, to evaluate the larynx, we must be familiar with the intricate anatomy, because it's a wonderful organ which is supported by various membranes, muscles, and the cartilage being held together, and the most important human nerve, recurrent laryngeal nerve, that gives us the humanity of our voice and speech. But what more important is that what we need to know is roots of exolaryngeal spread. These preform pathways, membranes, and neurovascular bundles are ready-made pathways for the tumor spread. As you can see here, the thyroid membrane, the preepiglottic space, the cricothyroid membrane, the preform pathway of superior laryngeal neurovascular bundle, and the cricoarytenoid joint. Similarly, the direct cartilage spread through anterior commissure, the thyroid cartilage, and posterior escape into the postcricoid region. So these anatomical pathways a surgeon must be aware to anticipate pathways of spread, as well as plan your conservative surgeries so as to you understand where and how the tumor is spreading. The staging, when you look at these two slides, it is quite busy, and don't please get confused. There is T1 to T4 for all subsites, supraglottis, glottis, and subglottis, and similarly here for hypopharynx. But to simplify it for you all and put it in a nutshell, divide it into three things: early lesions, intermediate lesions, and advanced lesions. For any subsite, may it be glottic, supraglottic, subglottic, the T1 or T2 lesion is a single or more than one subsite involvement, but without vocal cord fixation. This is important here. But T3 lesion is a lesion which is intermediate, that could be involving laryngeal spaces, inner cartilage, or what we call as 4 Ps, that is perichondrium, postcricoid, pre and paraglottic space, and vocal cord fixation. This part here is very, very important. I'll come to it why. And the advanced lesions T4A, where they have gone out of the laryngeal cartilaginous framework, and the inoperable ones, that is carotids, prevertebral fascia, and mediastinum. So if you by and large remember this division, you should not be confused about T1 to T4As for individual subsites. So when coming to the initial workup, this is for all subsites in the body that you take a detailed examination, image your patient, and plan the treatment. So to begin with, when you listen to your patient, there is specific clues that your patient might be able to give you. A glottic cancer usually will present early because of early voice changes, and in advanced stages they'll have dyspnea and stridor. Whereas supraglottic cancers will typically present with change in vocal resonance. They'll have dysphagia, odynophagia referred to ear pain, otalgia, and late again stridor, dyspnea, hemostasis. Subglottic cancer present by airway obstruction and laryngeal fixation. Similarly, lymph nodal patterns, the supraglottic cancers have a very rich lymphatic supply. They have the highest regional incidence of metastasis, that is level 2, 3, 4, and more commonly bilateral metastasis. This has bearing on your treatment planning as to whether you radiate bilateral neck or you operate bilateral neck. The glottic cancers, They are having low metastasis rate because they don't get access to the lymphatics so early into their course of progression. So the lymph nodal echelons are again 2, 3, 4, prelaryngeal, pretracheal and paratracheal. The subglottic, pretracheal and mediastinal nodes. A word about hypopharyngeal cancers here. The hypopharyngeal cancers usually will present in a late format because there are no anatomical barriers, as opposed to, let's see, in a glottic cancer, which is bound by various spaces and membranes. So it does not progress as rapidly as a hypopharyngeal cancer. So the hypopharyngeal cancers also will present with non-specific symptoms of sore throat, dysphagia, bloodstained sputum, which will get treated by various other diagnoses. Or more often, they will have a neck swelling as an earliest symptom because again, hypopharyngeal cancers get access to lymphatics very early in the course of time and they have a high incidence of metastasis. So it is very rare for anyone to find usually a T2 hypopharynx cancer. Again, relevant history. In a patient's relevant history, you should ask about the general appetite changes, breathing difficulty, weight loss. More important is socioeconomic history. What is his occupation? How much is the demand on voice? What is his employment status? Is he a manual worker? If he is a manual worker lifting weight, loss of Valsalva manure post laryngectomy is going to affect his employment. What is social support to undergo all these treatments? Again, major comorbidities. If the patient has renal failure, cardiac illness, then the patient might not be a candidate to undergo rigorous organ preservation protocols involving chemotherapy. And of course, if the patient is having aspiration on dysphagia. So all these pointers will be important to plan your treatment. The general examination, the nutritional status of the patient is very, very important to go through his treatment, either may it be organ preservation or a surgical management. While evaluating a patient, we have to evaluate patient in the office. In the olden days, we used to do this indirect laryngoscopy, which has been replaced by a Hopkins rod examination or a flexible fiber optic scope in most of the clinics, wherein you map the lesion, see the fixity of the larynx, and in certain cases take biopsy as well. So what are the goods and bads of a fiber optic evaluation is that it's an office procedure, it gives you good optics, the patient is comfortable and a biopsy can be taken. But there are certain downsides to it, such as you cannot manually palpate the disease, that is tonsil base tongue. You cannot see the fixation of the arytenoid versus the cord, and there are certain inaccessible areas like piriform sinus and postcricoid region. After you have primarily done a scopy on your patient, then we need to go to imaging. So for all laryngeal and hypopharyngeal cancers, the first line of imaging is always most of the times is going to be a CT scan, a contrast enhanced CT scan. What you should order is CT scan contrast enhanced. It is thin cut larynx, 0.75 to 1 mm cut in a plane parallel to the vocal cords. It gives us submucosal spread and deep structure involvement. Why thin cut laryngeal CT is that, especially in a lesions that are involving vocal cord, supraglottis, if we have a 5 mm cut, we are likely to miss the finer details of the tumor involvement. So in a larynx, always remember that ask for a thin cut CCT larynx. Also, CT is more or less universally available and it's a faster image acquisition. So in a CT scan, we get a lot of information about tumor involvement, the deeper structures, the space involvement, nodes, operability, most importantly the cartilage involvement and the exolaryngeal spread. So this will help us to stage our disease. So in this, as you can see, there is a frank destruction of the cartilage by the tumor. There is tumor involving the preepiglottic space. This is your epiglottis, this is the hyoid, this is the preepiglottic space. Again, tumor in the preepiglottic space. So it is a very good anatomical delineation. But there are certain scenarios where you want to do an MRI, because MRI will give us a better soft tissue delineation. And it has a very high sensitivity for cartilage involvement. So when do we want to know this is when we are considering an organ preservation protocol and when we want to rule out cartilage involvement, or when we are considering a transoral laser surgery and we don't know whether there is minimal cartilage erosion. One does an MRI because it has a high negative predictive value for cartilage involvement and we will use it as a problem solving modality. But the first imaging will always be a CT scan. And also PET scan. Where will you do a PET scan? So the PET scan will be usually indicated for hypopharyngeal cancers, any cancers like supraglottis which have got bilateral bulky metastasis to rule out distant mets. In an early glottic lesion, which is still confined within the framework of larynx, you may not need a PET scan to rule out distant mets. A CCT head and neck with the NCCT thorax is good enough. The next is a microlaryngoscopy. A word about microlaryngoscopy, because it's not, my slides are not visible. Somebody has texted slides not visible. One minute. So it's showing my screen being shared.
They are visible. They are visible.
Hello? It is visible now?
Sure, your slides are visible here.
Okay, thank you. Yeah, no, somebody texted in this not visible. Yeah. So a word about microlaryngoscopy, as to you often don't do it. How it is different from a direct laryngoscopy is, first of all, it is usually done for early lesions of a vocal cord and supraglottis. We will suspend the larynx using a scope and a suspension system. So that leaves two hands of the surgeon free to perform any procedures or biopsies. By using the magnification of either microscope or a 0-degree endoscope, we can do a very detailed assessment of a lesion, as you can see here. You can even see the vessels on a vocal cord. It can both be diagnostic as well as therapeutic by the laser excision, and a very detailed assessment of the spread can be done. So this is microlaryngoscopic assessment, very important to prior to managing a patient of early vocal cord lesion, because accurate mapping will stage the disease and we can take a treatment option here. The next common thing is direct laryngoscopy, which is performed under anesthesia using a regular direct laryngoscope, wherein you will systematically evaluate the supraglottis, glottis, and hypopharynx. The advantage is that we can access hidden areas such as pyriform apex, postcricoid, and tonsils, can palpate the disease, and also can take a biopsy, of course. And better planning of surgery and need of reconstruction can be done here, rather than the fiber optic laryngoscopy. However, it does not allow us to evaluate the lower extent of the cricopharynx and esophagus. We will require a transnasal esophagoscopy for that. It might decompensate the airway if a patient has a critical airway obstruction, and it of course involves anesthesia with its risk. So now coming to a role of speech language pathologist. A speech language pathologist is an integral part of managing your larynx in all stages of larynx and hypopharynx. In an early lesion, which is T1, T2, a voice assessment is very important prior to starting treatment, because it will serve as your baseline. It will give you an idea of overall voice quality, and also in follow-up, a regular voice assessment must be done to see your outcome, how the treatment, either surgery or radiation, has affected patient's voice. In a intermediately advanced stage, the functional assessment of larynx. It is a very important consideration if the patient is aspirating or having a breathing difficulty, which will preclude all organ preservation strategies. So simply starting, it can be done by a 100 ml water swallow test by even a clinician, wherein coughing on drinking water will guide us to possible aspiration, and then an instrumental swallowing assessment in terms of fees or video fluoroscopy can be performed to see what is the grade of aspiration. So won't be going into the detail of PAS score and so on and so forth for the lack of time. And of course, in post-laryngectomy rehab voice evaluation, a role of SLP is very important, because prior to surgery, a patient must be counseled, he must be mentally prepared to undergo the physiological changes of total laryngectomy. All the options of TE prosthesis, electrolarynx must be explained to the patient with videos, if possible making him meet with the other cancer survivors. The patient training is important. And also in the post-op period, whether the patient is speaking, if there are problems with the TEP, any troubleshooting needs to be done, a replacement needs to be done, or the stomach care, an SLP is an integral part of your management team. So coming to the broad overview of treatment planning. So as we said, we divide these tumors within 3 groups: early, intermediate, and advanced ones. So in an early tumor, T1, T2, usually will have a mobile cord. It will be restricted to one or maximum 2 subsites, and pre and paraglottic spaces would largely be free. So here we will use a single modality treatment. It can be radiation or surgery, depending on various factors such as availability of expertise, lesion anatomy, patient's preference, so on and so forth. In an intermediate patient, that is T3 or very few T4s, it will be a fixed hemilarynx. It involves into pre and paraglottic spaces. There might be very minimal exolaryngeal disease, but the cartilage framework must be intact. Here comes in the discussion about whether the patient should undergo surgical treatment or organ preservation protocols. And advanced T4s, which are the exolaryngeal spreads with cartilage erosions, they will undergo upfront surgery with appropriate adjuvant treatment as seen by the histopath report. But be mindful, in all of these treatment planning, the primary goal of the treatment is always going to be oncological control. Any treatment who are equivalent on the terms of oncological control, then comes the second point, whether voice quality, functionality, preserving of the larynx. Any treatment that compromises your oncological outcome should not be taken as a first choice. So this is a general, let's say, an algorithm for, let's say, a T1, T2 vocal cord lesion. If there is expertise and resources are available and the lesion is suitable, they may undergo laser excision. Or in these cases, only radiation can be offered and kept on regular surveillance. In cases of recurrence, if again post-RT recurrences, if organ preservation surgery is possible, they may be offered same, but these are very small categories. Or otherwise, they might undergo open surgery in terms of transoral laser or a partial laryngectomy. The recurrences following a transoral laser resection can be again salvaged by a re-laser if possible. If not, other options such as RT or partial laryngectomy could be offered to them. Coming to a few words on larynx preservation. So as you all, Dr. Somshekhar has rightly said, this is the commonest thing that is being treated for the patients in the current era. So how do you define larynx preservation? So it is either a use of a surgical or a non-surgical modality for avoidance of laryngectomy, preservation of speech and swallowing. So the requisites are that the person needs to have nasal breathing, oral speech, normal oral speech, and survival without aspiration. All these three criteria must be satisfied to call it a successful laryngeal preservation. So in various laryngeal preservation studies, various endpoints have been assessed, such as what is laryngectomy free survival, what is leukoregional recurrence, and disease free survival. We'll come to it a later date. So how do we select patients for organ preservation? As I said, it should be a T3 or a very select T4 laryngeal cancer, minor thyroid cartilage erosion of an inner perichondrium, must be a functional larynx. As we said before, all the prior testing, instrumental testing must be done to confirm that there is no micro aspiration and there are no signs of aspiration and there is no breathing difficulty. Again, the patient must be having a good performance status. Age should be suitable. All the trials have told us that the age less than 70 is more suitable for organ preservation protocols. No major comorbidities that preclude use of chemotherapy, and all these anatomical factors. So when we say organ preservation, what do we mean by organ preservation? So there are multiple strategies one can use for organ preservation. The most common of which is going to be chemoradiation. That will be 70-gray radiation along with a concurrent chemotherapy. Transoral laser surgery, this can be offered for a minimally paraglottic involvement T2, T3 lesion, but this is again available in very few select centers with required expertise. And open partial laryngectomy is also a third option which will preserve nasal breathing and normal speech. But again, in the current era of chemoradiation, this has been largely restricted to post-laryngectomy salvage cases or cases that are not suitable to chemoradiation, such as non-squamous histologies. When do we consider surgery? So the gross indications, absolute indications of surgery are the cartilage erosion, exolaryngeal spread, when it is a salvage option in recurrence or residual disease post-CTRT, the patient having dysfunctional larynx, that means either the patient has stridor, has undergone tracheostomy, or he is aspirating on your evaluation or is requiring Rice tube, that is dysphagia, for his feeding purposes. Again, for a non-oncological reason such as post-chemo radiation contour necrosis or pathologies other than squamous carcinomas, which are not very radiosensitive, such as adenocarcinomas, melanomas, so on and so forth. So again here, how do we decide whether the patient goes on organ preservation or a surgery is extremely important? If the patient satisfied all criteria for organ preservation, then only this should be considered, because the trials have shown us that the survival outcomes of a unsuccessful chemoradiation and a salvage surgery are inferior to that of patients who have not required total laryngectomy. And most of these patients might not be amenable after receiving radical chemoradiation. So again, patients' comorbidity, preferences, local expertise, all the important factors to assess your treatment options, especially in the intermediate T3 group. The T1, T2 is always single modality, T4 is surgery without any brainstorming, but this T3 select T4 group is where you should evaluate patient perfectly, stage it properly, and then take a call. So here is again a treatment option summarizing. Early glottic single modality treatment. TLM can be offered for larynx preservation in a select case. Advanced cases again are multiple modality therapy, CTRT. Either it is organ preservation surgery in some cases, and advanced larynx again total laryngectomy. So, sir, should I go on to the trials or should I go on to the parts where larynx, TEP, rehabilitation, and so on and so forth? Because I have kept few slides about organ preservation.
Yeah, I think rehabilitation you do first, then little bit cover the trial. There is a time. Please go ahead.
Okay, so then I will just try and see other presentation, and I will show the other presentation. Is my screen visible here? I will just share one more presentation, sir.
Yeah, screen was visible, no problem. You can go ahead.
This is visible right now?
Yeah, visible.
So now a few words on post-laryngectomy rehab as requested by sir. We have discussed why will we do a laryngectomy, that is in advanced T4 laryngeal cancers, or the patients who are failed organ preservation, or those who are unsuitable for organ preservation. As we all know, the functions of larynx are breathing, prevention of aspiration and speech, which are all going to be lost after doing a laryngectomy, and they will have a major physiological changes and psychological impact on the patient. So these are the alterations that the patient will undergo, that is changes in respiration, loss of smell. This is an important thing that we need to forget. We tend to forget that the patient is going to have a loss of smell. Then again, changes in normal swallowing because alterations in a cricopharyngeal sphincter due to surgery, and inability to strain or weight bearing. This again has an important bearing on a person who is going to be a, let's say, manual laborer who lifts weight for his livelihood. And most importantly, loss of speech. So how do we rehabilitate the patient after laryngectomy? So all these components will together form post-laryngectomy rehabilitation, such as voice rehab, pulmonary rehab, swallowing, olfactory sensation, and overall quality of life. So coming to a normal physiology of phonation, it is usually a source and filter theory, wherein your initiator, that is lung, which powers the voice, will generate a resonator, that is vibrator, which is usually your larynx or pharynx, and then the articulators in the speech, lips, tongue, and palate will form the final speech. This is your source filter theory, based on which we form the various pathways of post voice rehabilitation. So options of rehabilitation are either surgical methods or non-surgical methods. So traditionally in like 1900s or early 20th century, various methods were used such as pharyngeal and buccal speech, esophageal speech, forming of shunts. But currently now we have progressed to our TEP speech. So coming to the mechanism of speech, the first is laryngeal speech, which is a normal speech, wherein your initiator is pulmonary air, voice is generated by glottis. But in an electrolarynx, which is another option, the initiator is by a battery and the vibrating membrane in a battery is your voice source. In an esophageal speech, the patient swallows esophageal air, he again excludes it out, and the vibration will of the neopharynx will cause the voice the voice production. And the lastly, T fistula, which is the most common use these days. Again, the initiator is pulmonary air and the source of voice generation is neopharynx. So a word on neopharynx. The esophageal speech was initially devised by Gluck, wherein swallowing of small amounts of air up to 40 to 70 ml by the patient and a controlled regurgitation, which was later on modulated by your tongue and lips, will generate voice. So the problems with esophageal speech are the speech is in short successions. That is, the patient cannot talk for a long time. The mean phonation time is not long. The success rate for intelligible speech is very variable, ranging from 14 to 75%, because it solely depends on how dexterous or how adept the patient is at producing this voice. So in the current era, the indications for esophageal speech will be those who are not affording TEP or electrolarynx, those who have been non-speakers or failures of TEP, or as an interim method till the patient completes his healing and starts to use a electrolarynx, let's say. The advantages of electrolarynx are that the esophageal speech is that it is free of cost. There is no conspicuous, let's say, using device outside from the neck. It does not depend on any instrument. It's hands-free, and it will not interfere on your other methods of speech rehabilitation. But the disadvantages are that it is difficult to acquire. The success rate of esophageal speech is very low. It requires intensive training. The voice quality is quite inferior, and the patient cannot speak long sentences, that is low mean utterance length. So the next options came out to be the artificial larynxes. People tried to devise either a electrolarynx or a pneumatic larynx, which generated a voice source and which was articulated in the oral cavity and oropharynx. But these all are external devices. Here you can see an electrolarynx. It is a vibrating electric device like a torch, which is held against the submental region or in rare cases against the cheek. But it gives a robotic voice. It is a battery operated device. So it appears as if like a robot is talking. It has to be trained quite extensively. Like in a pre-operative period, a patient should be started on training for an electrolarynx. The other options less commonly used historically was a pneumatic electrolarynx, which virtually no one uses these days. Against the advantages of the electrolarynx are that it is a short learning curve. The patient can have immediate speech even in the interim period. It does not delay your TP speech or other forms. But again, it is battery dependent. It has a very robotic, monotonous quality of the sound. It has recurring expenses of changing batteries, and it is the least socially acceptable method of voice rehabilitation out of all the other options that we have. So the most commonly is the tracheoesophageal speech that we all are using quite frequently. Again, here the physiology is that the air is exhaled from lung. It is diverted from esophagus via the fistula to the neopharynx. The air is sucked in from the trachea, then from the TE valve, which is a one-way valve. It is diverted to your esophagus. Here is your vibrating neopharyngeal segment, and this voice generation is again articulated by your palate, lips, tongues and teeth to produce voice. So the anecdote about it is that it was accidentally discovered, and a laryngectomy patient was so frustrated by loss of voice that he tried to kill himself by an ice pick, and in the result created a fistula between trachea and esophagus, which fortunately did not kill the patient, but then the patient started speaking by this mechanism. So this is how a TEP physiology will work. So the other option was surgical shunt. I will skip upon this. So there are various models of a TE prosthesis which have been initially Bloom Singers, duckpeals. Currently we are in the generation of Provox. The Provox also have grown from Provox 1 to Provox Vega, and now we have Provox Smart Insert, which are much easier to insert for a surgeon either in the OPD for a replacement or on table insertion. So again, historically there were types of TEP prosthesis. We'll skip this in the interest of time. So what are the advantages of TE speech are that it is very intelligible. A good dexterous patient can have a short learning curve, voice quality is good, and a high success rate of over 90%. but there are downsides to it, such as it is physician dependent for its maintenance replacement. Patient needs to have a good pulmonary reserve. So a patient who is very frail, old, has any pulmonary comorbidities, who cannot generate 500 ml of voice burst, will not have a successful speech. It requires a manual dexterity for not suitable for very old patients or those who are having any neurological conditions. And again, hand-eye coordination is required for a successful TEP speech. So the how do you select a patient for PE prosthesis? Is there various patient factors? A patient should be well motivated to have speech in the post-op period. He should not have the other problems such as frailty or hand-eye coordination, poor health status. He should be having affordability, because the cost of TE puncture at right now is somewhere around 30 to 40,000 per replacement. And although hopefully we would not require repeated replacement every year, the cost is a considerable concern for many patients. The patient should have social support to maintain and clean the TEP properly. And again, the issues of poor pulmonary reserve, vision, dexterity. The surgical factors is sometimes during the surgery we will not primarily opt to put a primary TEP in the cases such as how is the status of party wall. For example, if the patient has undergone a salvage surgery with the extensive dissections, tissues are bad, you are putting in flaps. Of course, in a gastric pull-up case, the party wall is not in good condition, so the primary TEP will not be considered. What is the stoma size? If the stoma is too low, it is too narrow, putting in a TEP may not be feasible. And for a secondary TEP, a vibrating P segment is very essential. So there are two types of primary versus secondary TEP. Primary means we put it at the time of laryngectomy, and secondary puncture is when the patient has completed adjuvant treatment, the entire thing is healed, patient is oncologically controlled, then we consider using a secondary TEP. So primary TEP is only one operation, will result in rapid return to voice. But there is a downside to it, as in there is initially sensitive stoma, patient may have alteration in sizes of the TE prosthesis, and RT may delay the initiation of speech. In the secondary puncture, all these things are avoided, that the healing is good. There are no many tubes. The size can be done after the patient's stoma has settled, but it will require two operations. The patient loses speech for a longer time, that he will require electrolarynx or some other method to be used in the interim. There are higher chances of failure if there is a secondary TE puncture, maybe because of post-RT fibrosis, or there is no vibrating PE segment. So when we are doing a TE puncture, there are certain surgical prerequisites for it during surgery, and also when we are not doing surgery, some of these things, not doing a TE puncture primarily, some of these should be done. First of is cricopharyngeal myotomy. The cricopharyngeus muscle is a superior esophageal sphincter. It causes hypertonicity in the postoperative period. So a myotomy, a vertical myotomy is required to divide these cricopharyngeal muscle fibers to prevent hypertonic segment, to facilitate speech and also swallowing, because if there is constriction of this cricopharyngeal sphincter, there will be dysphagia in the postoperative periods. The stoma needs to be of a good size, and it has to be a horizontal stoma. The size is usually considered adequate size of patient's thumb. One has to cut the medial end of bilateral sternocleidomastoid muscles so that they don't close onto the stoma and cause vertical stenosis. And it has to be a D-shaped stoma which is of adequate size for the TEP to be maintained. Postoperatively, the care of the patient needs to be done properly. Again, coming back, when we are inserting the TEP, it is usually inserted about 5 to 8 mm from the stoma. A very deep TEP will cause problems for maintenance and cleanings, and patient might not be able to vocalize postoperatively. So again, there are multiple choices of speech rehabilitations, and we should make a considerate decision after a thorough discussion with the patient as to what are patient's goals, what are his affordabilities, will the patient be able to manage the TEP in the post-op period, can the patient afford the recurrent cost of the TEP in case of problems, and all these things in teamwork should be decided about. The patient should get a TE prosthesis or patient should go for an electrolarynx. So again, your speech and swallowing therapist is a very important part in this to make you help to do this decision. So that's all from my side. Then maybe sir, we can go on to questions or any other particular issues you would like me to cover.
excellent presentation. And this rehabilitation part is very important, which you have really talked about very well to our students. Thank you.
Thank you, sir.
So, what would you like more to discuss?
Vidisha?
Yes, sir.
Yeah, excellent presentation. I think you have covered from basics to advanced rehabilitation, everything in a excellent way. Would you like to tell the students, especially about reconstruction and its implications on voice rehabilitation, if any?
Yeah.
Isha, excellent. Everybody is asking, please speak about trials.
Okay, yeah, so we can do that.
Yeah,
I
we
had
still
made
have
a-
time. We can do that and then open the Q&A section and chat box at the end of it, and also concentrate on the reconstruction what Dushan told. So maybe in 15 minutes, if we can cover the important trials,
Okay.
neo-adjuvant, adjuvant, and voice preservation protocol, so students can take screenshot and sort of expand on that. Then after that, open Q&A and chat box section and answer the doubts, and also a little bit touch upon the reconstruction options in the
is an attempt nasal breathing, oral speech, and oral eating for a patient. So the options, as we discussed, will be doing a chemoradiation, doing open partial laryngectomy, or transoral laser surgeries. So to give you a perspective, the era of actual organ preservation begins somewhere in about late 80s, wherein the chemotherapeutic agents like 5-FU and cisplatin were invented, and there was advent of more advanced radiation techniques such as cobalt-60 and LINAC. Till then, it was all a total laryngectomy, and from here on, various trials started to be devised, such as laryngeal preservation VA trial, RTOG trial in 2000s, and VEGF trials. And another breakthrough was taxanes, which era we are currently in. So the very first important trial that all students should know is a VA trial. It was a trial done in early 90s. It was for laryngeal cancers. So it was named as induction chemotherapy and radiation versus surgery and adjuvant RT. So in this trial, only laryngeal, that is glottic and supraglottic patients were taken. They were locally advanced stage, that is stage 3 and stage 4. In this trial, what they did was they divided patient in two arms. A patient in the first arm underwent surgery followed by post-op radiation, which was the standard of care till then. And in the second arm, patients were divided for induction chemotherapy. In this, patients were given 2 cycles of induction chemotherapy, after which the response assessment was done. If the patient had at least more than partial response, then a third cycle of chemo was given. And anything less than partial response, the patient was subjected to surgery followed by radiation. So in this trial, what they found was at the median follow-up of 33 months, there is no long-term follow-up here. In about 64% patients, laryngeal preservation was possible. Okay, and however, there was no difference in 2-year overall survival. So this is a most important thing, like we discussed before. Any strategy that compromises your survival is not an ideal option. So the first thing was there was no difference in survival, and again, laryngeal preservation could be done in about 64% of the patient. So, but there was a small caveat to this, that local recurrences were again higher in this induction RT group, which needed to be salvaged later on. So the conclusion of this trial was induction chemotherapy followed by definitive RT was an effective means of preserving lyre without compromising overall survival. So this was the first landmark trial. Following which, there was another, based on these findings, for a laryngeal subgroup I am talking about, another major trial was done, which was RTOG 9111. So in this trial, randomized trial, it was done evaluating concurrent chemotherapy for carcinoma larynx. We will come to the hypopharynx a little bit later. So in this trial, there were 3 groups. The first group was only radiation. The second group was chemo radiation, that is 70 gray radiation and cisplatin at 3 weekly regime. And third was induction chemotherapy followed by RT. So in this, again, after induction chemotherapy, if there was at least partial response, then a third cycle and RT was given. If there was less than partial response, go to surgery and PORT. So in this trial, the primary endpoint was overall survival and disease-free survival. So what did we see in this trial? So looking at these three arms, the laryngeal preservation at 2 years was maximum 88% in concurrent chemoradiation. Overall survival was similar in all the three groups. This is the important thing I repeat again, that there was no compromise in overall survival. Laryngeal preservation was maximum in concurrent arm. However, there was certain things such as loco-regional control also was maximum in concurrent arm, but the distant failures were more in the radiation arm where there was no chemotherapy. So this trial said that concurrent chemotherapy gave higher larynx preservation rate than either induction or RT alone. When you look at these survival curves, don't get worried about these curves. This is radiotherapy concurrent, chemo followed by radio and radiotherapy alone. So if you see, the laryngeal preservation was again best with concurrent chemoradiation. Loco-regional control was again best with concurrent chemoradiation. And also there were very few, significantly fewer local failures. So patients had a better treatment options again with concurrent chemoradiation as compared to the other arms. So then they concluded that concurrent chemotherapy should be standard of care when we are attempting laryngeal preservation in locally advanced disease. But what happened at 10 years, when this trial was followed up to 10 years, what was seen by that laryngeal preservation was both similar by chemotherapy based regime. That means either concurrent chemoradiation or induction followed by RT. Had similar laryngeal laryngectomy free survival better than RT alone. But there was another concern that the patients who were in concurrent chemoradiation arm, there was higher incidence of unknown death. So this is still under investigation because they have postulated that patients who were in concurrent chemotherapy arm, they might have died of lead toxicities or there were silent aspiration episodes. So this is another finding of this 10-year follow-up of this study. So another similar trial was done for the hypopharynx groups. The first two trials that we saw were for the laryngeal cancers. So laryngeal and hypopharyngeal cancers have distinct biology, they have distinct disease progression. So this trial, URTC 24891, was designed in again early 19s, similar to the era of VA trial. It was done for pyriform sinus hypopharyngeal cancers, in which they took T2 to T4A cancers, stage 2 to 4 tumors, which was an equivalence trial for all this. The design was similar. The first arm was immediate surgery and give adjuvant treatment. And in the second arm, give induction chemotherapy to the patients, 2 cycles of cisplatin and 5 uracils. If less than partial response, go to surgery. If there is more than partial response or complete response, give again 1 more third cycles and then concurrent chemoradiation. So all these patients would be followed up later. If they had any relapse, would undergo salvage surgery. This design was similar to the VA trial but for a hypopharynx subgroup. So in this trial again, what they saw was local control rates were similar, median follow-up of about 51 months, and the estimates of retaining a functional larynx were good in the induction chemotherapy arm. That is, at 3 years, 42% patients could save your larynx, and at 5 years, about 35% patient could save the larynx if you gave induction chemo plus RT. And again, one more advantage in this group was the patient who received chemo had fewer distant metastasis rather than the surgery versus RTM, which was an added benefit. So 40% patients could save their larynx, and plus you had a reduction in your distant metastasis. So coming to again survival, which is again your first priority in any treatment option, the survival was non-significantly different. So again, this trial concluded that induction chemotherapy followed by radiation can be a new standard of treatment for phase 3 larynx preservation studies. But again, now we are in the era of a TPF regime, we'll come to it later. Again, this trial was followed up for about 10 years. There was no significant survival difference. even at the 10 years, the overall survival remained same. So the authors again conclude, this has come out in 2012 after 10 years of follow-up, that induction plus RT did not compromise local control or survival. That remained anyways poor because it is 10%. Hypopharynx is one of the worst subsets in head and neck cancers, but more than half the survivors were able to retain their larynx. So it is a legitimate treatment strategy for hypopharyngeal cancers that are suitable. So what do we get from this is that the non-surgical organ preservation is a feasible strategy for select subgroup of patients, and concurrent chemoradiation with cisplatin remains standard of care in organ preservation for laryngeal cancers. But when induction chemotherapy plus RT is given, it results in better overall survival. So when you are looking at preserving larynx, concurrent chemotherapy plus radiation gives you the best results. But when we are looking at long-term survival with larynx, induction therapy might be better at about 10 years. And when any laryngeal preservation strategy should be considered, functional laryngeal preservation and survival should be a combined endpoint that should be taken into consideration. So I will, I think, stop here and we can take any questions after this.
Yeah, thank you. These last 2-3 parts were extremely useful. So I think you can open Q&A and chat box and open and answer the questions.
Okay, sir. Sorry, I'm not able to get the question thing here. Can we? Yeah, got it. Sorry. So we have covered the trials. One or two candidates have asked for trials. We have covered basic trials in this part. So one more question is, can you please explain about size of TEP device 8 mm and put 6 mm TEP device? So as a rule, why we consider 8 is when we are putting a primary TEP, that is in the time of surgery, the TEP that we usually put is 8 mm, because traditionally what happens is during surgery your party wall is supple. What need to you to understand is what is 8 mm. Okay, 8 mm is the distance between the flanges, the esophageal flange and the laryngeal flange of the TEP. So if you have a shorter TEP, let's say a 6 mm TEP, what will happen is that the TEP can get embedded into the party wall and it can cause necrosis. So when we are putting a primary TEP, traditionally a 8 mm TEP is put, and when we are doing a secondary TEP or we are doing a TEP replacement, then we need to size a TEP properly. In that case, for a replacement TEP, you can put a 6 mm if your party wall is thin. But when you are putting a upfront TEP or primary TEP, a 8 mm TEP is put. Anybody needs to ask any other question about it?
Yeah, I think that's fair. So next, I'm just thinking.
I think we have covered.
Yeah, that's all. I think we have covered everything.
Yep.
Thank you very much, Vidisha. It has been lovely. This was also I would request students, first to understand the laryngeal surgery, first to read the proper anatomy of the larynx, do applied surgical anatomy of larynx, and then you understand the various process technique, and also read about what is pre-epiglottic space, what is its significance in T status, paraglottic space, boundaries, and what is its significance, and all the trials which Vidisha showed. It's a very vast topic, but I'm very happy she covered it extremely well. Thank you very much, Vidisha, on behalf of NBMS, DNB board students and myself. A warm felt thanks to you for taking your time and preparing this topic and sharing your knowledge. Thank you very much and have a nice day. Over to you, Arifji.
Thank you very much, sir. It was a pleasure to have you.
Thank you. Over to you,
Thank you so much to all faculty member and trainees. Sir, I think there is one question in chat box if you can check.
Yeah, let me check. Somebody has asked, how do you manage post-laryngectomy leak and especially post-chemo RT, which may be common? So
Yes.
what are the measures we need to do?
So basically, unfortunately, whatever method of closure has been done, it is shown that your method of closure, whether you do continuous, intermittent, various types of sutures, have not been shown to have any significant difference in the types of leak. It usually depends on your technical prowess, that is how good your suturing is. That while doing surgery, one should have a tension-free closure. Your suture should not be very tight. The mucosa should not be strangled in between so that it should not undergo vascular necrosis. So these are the things that you can consider during surgery. One more tip to it is that, especially if you're doing a salvage surgery, and then if you feel that your mucosa quality is not good, the post-RT mucosa is very thick, leathery, or it is not pliable, either consider doing a augmentation in form of patch PMMC, because that will prevent formation of a leak, or either also consider putting a onlay PMMF. What I mean is, we perform a primary closure of the larynx, and on top of it we harvest a PMMF flap and put it as a second layer to contain that leak. So these are some surgical measures that we can consider, whether to augment the larynx preemptively, especially in a salvage setting, or whether to put a onlay PMMF to contain the leak. If you are having a particularly endolaryngeal disease, there is no piriform resection, but you are not happy with the quality of mucosa because of extensive chemoradiation. Then coming to how to manage the leak is, first of all, you should divide the leak into two types, whether it is an early leak or it is an late leak. A early leak is that it occurs in a day 2 or day 3, and usually most of the leaks will occur about day 5 to 7. So any leak that occurs early usually is due to a technical failure, and you would probably need to take this patient back to theatre early and suture whatever has been loose. Okay, so but the first principle of managing any leak is isolate that leak. If you are having a stoma, we should put a tracheostomy tube, cuff tracheostomy tube, to prevent aspiration for this patient. Then lateralize this leak. Either you put a corrugated rubber drain, open out lateral sutures so as to you drain out all the saliva. Why it is important is that accumulation of saliva in the operative field will cause vascular digestion. All the salivary enzymes will cause your vessel walls to erode, and there will be a risk of having a blowout. So any leak, even a smallest leak that is suspected, please open out the sutures, give repeated washes and drain out all the saliva. If it is infected secretion, start the patients on antibiotics so that the infection can be brought under control. So usually if it is small amount of leak, or started a little, usual 5 to day 7 leaks, which can many a times get managed by their own, do a conservative management. Usually in an upfront setting, we arbitrarily put it at 2 weeks, because the patient also has to undergo radiation. We can't have the patient managing wound for about a month and then start adjuvant radiation. So for about, give it 2 weeks. If it is not reducing, we need to take the patient back to OT, either suture it, put a cover flap, or put a patch PMMC. In a salvage setting, again, take all these precautions to prevent a blowout. A blowout in a salvage setting is a disaster. So well lateralize your leak, drain out all the saliva, and then you consider whether you want to take a patient to OT. You can give it some more time, because post-RT tissues will take time to heal. So within 3 to 4 weeks, probably the leak will heal by itself. It is not a major leak, and if it is not having exposed vessels. So that is how in general you will manage your leak. Okay.
Yeah, thank you, Vidisha. Maybe only last question we take again. People have written, suppose we have done a laryngectomy, there is an isolated stomal recurrence alone. The problem is, once we have a recurrence at the stoma, it is never just a tracheal problem.
Yes.
Always the diapharynx will also be affected, and there is no wide excision. How do we manage those if already radiation has been completed before?
So again, so if there is radiation has been completed before, so there is a classification of the stomal recurrence. Okay, so it is a Sisson's classification which tells you how deep is your recurrence. So grade 1 or 2 can be probably a surgically salvageable possible, but grade 3, 4 are usually the ones which are extending deeper down into the mediastinum and abutting great vessels. In that case, you will not have a surgical options. But if you don't have RT as your backup, and if your stomal recurrence is small, that is grade 1 to grade 2, a surgery might be attempted. But like if it is a salvage surgery and the DFI has been good, like let's say more than 2 years, speak to your radiation oncologist. They might be able to give localized radiation in the form of boost to the particular area to contain that recurrence. So if all of these strategies are not possible, then the only option we are left with is palliative chemotherapy.
Okay, thank you very much. Thanks. Over to you, Arifji.
Uh, Thank you so much to all faculty members and trainees for joining in this session. I think most of the queries have been answered and we can conclude the session. So thank you everyone for joining in. Have a good day. Thank you.
Thank you
Thank you,
all of you.
everyone. It was a pleasure. Thank you, Dr. Somshekar.
Thanks, Vidisha, again. Bye.
Thank you.